talk? Yes, please.
All right. I just lost everyone on the screen. Moment of terror. Came back. I love computers so much. I hope everyone is having a good week. Thanks for being here. I know it is the height of summer and travel for many, and so thanks for being here. I think that we're doing just our usual housekeeping pieces until we jump into OHP Bridge. So next slide, please. I think we're doing probably roll call, but there we go. Welcome and roll call. Welcome. I don't have anything else exciting for welcome.
Good morning. So, okay, before we go to meeting guidelines, let's hit up roll call real quick for the Health Insurance Marketplace Advisory Committee. Good morning, everybody. My name is Shaggy Flowers. My pronouns are she, her, hers, and Shakanya, and I am the director of the Oregon Health Insurance Marketplace. I will be assisting with this morning's roll call. For HIMAC community members, if you are here today, can you please verbally acknowledge by saying yes, you are here today when you hear your name. So I will start with Gladys Boutwell.
Here on Zoom.
Thanks, Gladys. Stacy Carmichael. Charles Fisher.
Yes, I'm here.
Thank you. Ron Gallinat.
Here on Zoom. And I still can't get my camera to work for these meetings, but.
Okay, thank you for the heads up. Paul Harmon.
Here via Zoom.
Cheryl Lindsay Hopper.
Present by Zoom.
Thank you very much. TK Keene is the new DCBS ex officio, as he is the interim insurance commissioner. He's not able to join today, but he will be joining our next meeting in October. Shannon Lee.
Present via Zoom.
Kathleen Orrick. Director Claire Pierce-Roble.
Here on Zoom.
Om Sakinai.
Yes, Warshall.
Thanks, Om. Vice Chair Neshoba Temperley.
I'm present via Zoom.
Thank you. And Joanne Zumbrennen. Double checking because I think I saw her log on, but in case you are not easily able to unmute yourself, we will check you in later, Joanne.
Joanne was in the waiting room, so she's here.
Oh, okay, sounds good. Thank you very much, Dawn. So Lindsay and Neshoba, we officially have quorum.
All right. Thanks very much, everyone. And thanks for calling roll. Next slide, please. I'm gonna cover our meeting guidelines. Next slide, please. So we've shared these before, but by the way, I see Stacy in the chat box. Thanks, Stacy. We've covered these guidelines and protocols before, but we want to cover them each time to make sure folks know that we're committed to a safe and inclusive meeting. We're here to share different perspectives and different lived experiences. There are no bad questions. We would like to hear it all. We invite everyone to speak. If you have a question or you'd like to comment, you can raise your virtual hand, you can put it in the chat, or if technology is not working and you're a member of the committee, we'll make sure we check a couple of times so you can come off of mute. We do have Spanish interpretation. It's best if we can speak at a moderate pace, and that of course goes for the presenters. If you're able to be on camera, or if your camera is cooperating, I hear you, Ron, please be on camera, just because it helps us be together here in the virtual space. And we will take votes via roll call. Next slide, please. I'm not always great at this, but if everyone could please remember to state your name before you ask a question or make a comment, that helps certainly for minutes and for transcription. And then if you're a member of the public joining us, thank you for being here. There are a couple of public comment opportunities. As always, if you experience something unacceptable or unsafe or any behavior that makes you uncomfortable, please reach out, and Chicky's contact information is here. We'd certainly want to hear from you. That's not something we want anyone here to experience. Next slide, please. All right, so there are minutes in the packet. Folks might remember we had a couple of sessions because we had a quorum uncertainty, I guess you could call it, on the June 20th meeting. So we did a little bit of catch up. That's why there were 2 sessions. Looking for a motion to approve both sets of minutes, please, if someone is willing to make the motion.
Ron Gallinet, I so move.
Thank you, Ron. Is there a second?
It's Stacy Carmichael, I second.
Thank you, Stacy. Any questions, comments, other observations, corrections? Grab bag of minutes. Anything on that front? Okay, then I think we're ready to take a vote on the minutes, Chicky.
Copy that, Chair Lindsay. So HIMAC committee members, once again, when we are voting on various items, we need to call your name and we need to record your verbal yay or nay to pass the motion. So double check again. Ron Gallinet made first motion. Stacy Carmichael made the second motion. Gladys, how do you vote?
I approve.
Thank you. Stacy did second. Charles Fisher,
Yes.
Paul Harmon,
Approve.
Lindsay Hopper,
Chair votes yes.
Shannon Lee.
Approve.
Thank you very much. Kathleen, were you able to join us today? And how do you vote? Claire Pierce-Roble,
Approve.
Om Sukinai,
Approve.
Nishoba Temperley.
Vote to approve.
Thank you. And Joanne Zumbrennan.
I approve. Thank you.
Thank you very much. Motion passes and minutes are approved.
Thanks very much, Chicky, for calling the vote on that. Next slide, please. These are bridge updates, and I know I saw Sean's name up here. Do we have everyone we're expecting for this update? Hopefully.
I don't know if Tim's going to be able to make it today. I'm
Got
happy
it.
to present.
If you're willing to kick us off, please do. Thanks for being here.
Sounds good. So we wanted to share some updates about OHP Bridge lately. We've been working through some issues after rollout and making a bunch of policy changes as required here. So we have a few topics to run through today that get pretty complicated. First one is what we're calling the open enrollment coverage gap and start date adjustments to close that. We've also got another issue about annual income lower limits, adding a lower income boundary to OHP Bridge. And then we've also been working on some private coverage cleanup efforts. So just wanted to run through these 3 things today and then give some time for discussions. We're going to get really into the weeds of how eligibility works and whatnot. So please feel free to jump in with questions at any point during the presentation if you have things that would help clarify this for you. So with that, let's dive into the first of these. We can go to the next slide. So background context, if folks aren't aware, OHP Bridge is the new benefit for adults with higher incomes. To be eligible for OHP Bridge, you need to be between 133 to 200% of the poverty level annually. We'll get into that change in a few slides here. You need to be between 19 and 64, not have access to other affordable health insurance, which is also going to be relevant to one of these later, and have an eligible citizenship or immigration status to qualify. Benefits-wise, it's going to be basically identical to OHP Plus, except for the access to long-term services and supports and the health-related social needs like housing that we're rolling out through the waiver. Otherwise, it's exactly the same coverage, free costs, your coverage with no costs for members. If we go to the next slide, we have a quick reminder of how start dates work for OHP Bridge, as it's going to be relevant to the start date adjustments we're going to do on the next section. So for OHP Bridge BHP, which means all of the members who are not American Indian Alaska Native who can be eligible for OHP Bridge Basic Medicaid, which follows normal OHP start date rules, which usually goes back to the first of the month you applied in. So for BHP, for all the members who aren't Native American, the start date rules here are always going to give them a future start date instead. This is kind of similar to how the marketplace assigns start dates, but with a additional caveat of this is based on when we process the application, not when the application is submitted. So there's up to 45 days for us to process the application. And then uh, when that's processed, if it's in the first half of the month, they're going to be approved the first of the next month. So if someone's application is processed in the first half of October, they get a November 1st start date. If the application is processed in the second half of October, it would instead produce a December 1st start date. So there's up to 45 days for us to process the application, and then another 2 to 6 weeks before the benefits actually start. So that's going to be just OHP Bridge's normal start date rules. If we go to the next slide, that starts to get kind of complicated during open enrollment season, particularly when the marketplace won't let you re-enroll in a plan for the next calendar year if it thinks you're going to be eligible for OHP Bridge instead. We can go to the next slide. So because of that, plus the start dates stacking up, that can produce a several month coverage gap for people when moving from marketplace to OHP Bridge, specifically during open enrollment season. So we got federal approval to adjust the start dates back to the first of the year, essentially, and close that coverage gap retroactively. That way, the member could bill in any services that they had received from healthcare providers. As long as they're not in network with OHP, they'd be able to bill those services in to their OHP Bridge and get those paid for. So we will be rolling that policy out in September and sending letters to about 1,500 members who appear to have been sent from the marketplace and then ended up with OHP Bridge with relevant start dates in the first few months of the year. So those letters will be going out to members in September. We do expect this issue to happen to members as well during the next open enrollment season, but we're still working on what's going to be the policy for people to be able to who are affected by this in the next open enrollment. So this will be for this open enrollment or for the last open enrollment that happened, the 2024-2025 one. They're getting the notices in September, which is still in time for the timely billing, timely of any services they received. So we're working out the ones for next open enrollment. We can go to the next slide. Basically, the process here for members, as explained in the letter that they're going to get and whatnot, is first to contact us to get the start dates moved, and then the member themselves is going to need to contact providers to rebill the services because they're going to be the only one who knows which services they received since the bills never got sent to us. We will try to have our client services unit call out to them, to anyone who's actually moved the start dates in order to help them get those bills resolved, though. Until September, if you happen to run into any members affected by this, we would want to re-request that in September. Proposal for eligible members to get these start date moves would be they'd have to have applied through the marketplace system between November 1st and January 1st to be affected by the end of year cutoff on the marketplace side, and then ended up with an OHP Bridge start date in either February, March, or April. Then we'd be able to close that coverage gap for them back to the first of the year so they could bill any services they received in that time. They would have to actually be enrolled in marketplace coverage in the previous year, though. So this doesn't apply if they were just newly applying through that system. This also doesn't apply outside of open enrollment because of that end of the year cutoff thing is what's causing. Normally, the marketplace would let you stay on marketplace coverage until you reported your OHP Bridge start date to them if you're transferring between the systems. And then they do also need to have medical bills actually received during the gap. We're not going to extend coverage backwards if they didn't actually have services to receive and pay the CCOs for coverage that the member's not going to use. Next slide has a little graphic on how this all works. So starting from the bottom left, if someone updates their marketplace application in the first half of December, that's going to start the 45-day review period for their application. Marketplace might or would end up not letting them re-enroll for the new calendar year, though, and their coverage with the marketplace would end December 31st. They're still in that 45-day review period, though, until potentially the end of January. If we make that decision in the second half of January, that would produce a March 1st start date for this person, leaving that 2-month gap in coverage I've got in the purple dotted area there. That would be eligible for us to move back to the first of the year, though. That way, any services they received in that purple dotted time could get billed into OHP after the fact. So hopefully that makes some sense to folks. Any questions on this open enrollment start date move topic? I might have one more slide on this. I can't remember. Nope, it was okay. Topic. Charlie.
Well, this is great. Thanks for the presentation. I I guess I'm one just like trying to picture this from the perspective of someone going through it.
Mhm.
And is there going to be any communication to people that this like basically from when they apply that it's possible that they'll be able to get retroactive coverage? I'm thinking about like, they go to get services and then they they end up paying for part of it out of pocket, or I don't know, just all the thing, the challenges of not having healthcare, and then just like the financial implications of that. So is there going to be like communication to people that, don't pay the bill, or, wait until we tell you whether you have coverage with OHP Bridge before, paying this bill because it's possible it'll be covered? I'm just curious how like the communication to people during that interim period is going to happen so that they know that like this is something that possibly may apply to them, and so they don't, spend any money. And then I guess the follow-up is if they do pay the bill, will they be reimbursed through OHP Bridge, or how does that work?
So the gap in coverage happened earlier this year. We weren't able to communicate at all during that time because we didn't have this policy approved by the feds until in the last month. So we're going to be sending a notice out to the 1,500-ish people who specifically came through the marketplace system. We can see the application source and the start date they ended up with OHP Bridge on. So we think those people may be affected by that. We don't know 100% certain that they actually have bills or anything in that range. So we're sending all of the potentially affected members a notice that this is an option for them. It's going to be how we're communicating that part to them. For the services received in reimbursement, the provider needs to send the bills into CCO. If they've collected payment from the member, the provider would be the one to reimburse them once they got payment from the other source, if that makes
Got
sense.
it. Yeah. Okay. And then I guess I was interpreting this to be also forward looking, like we have the gap happened last year, but then this is a thing that's going to happen perennially going forward, or are you saying that this gap is solved going forward? And
The gap is going to exist going forward, like this problem of transferring between the
Yeah,
systems. We are
okay.
not certain if this is going to be an option for next year quite yet, nor do
Got it.
we're trying to adapt off of this iteration of it. That way we can look at different processes to work for the same problem next year, if that makes sense.
Yeah. Okay. Thanks.
But just to follow up on Charlie's question, though, I mean, we know it happened last year. What will the communication look like when someone submits an app and it's going to take up to 45 days? They may not have the effective date that they're envisioning, right?
Mhm.
And do they hold off on services? If they have a service, should they make sure they go to a CCO, keep copies of their bill? I mean, what does that communication look like to kind of help them through what is really confusing as far as like when coverage will start for them?
Communication is unfortunately very minimal. The federal platform only displays a message that their application has been sent to the state Medicaid agency for review. We haven't made a decision on that at that point yet, so we're not going to communicate back to the member before we've made that decision, unfortunately. So there's just this gap in the system. So after the fact notification is unfortunately going to be the only way we can identify these. So we're discussing the process for how we can try to address this next year as well and adapt from what we learned this go around. We're able to at least get this option for the gap that happened this last year, at least. So we're hard at work at trying to figure out how to adapt for the next open enrollment.
Sorry, I have another question. So, okay, I guess I'm not. Is this just a thing that's going to happen every year, and we have to fix it like each year on its own, or like is there not like a
Essentially,
longer term
yes.
solution that we can? Okay.
Part of this is also federal platform dependent, and as we eventually move to a state-based marketplace, we might have other options. So we're going to have to adapt around changing systems is kind of an expectation here.
Okay, but once we get the SPM up and running, then potentially we can, in a more consumer friendly way and more consistently, or more consistent way, prevent
I
this
don't want
problem.
to speak for our marketplace friends on what exactly we might put in the system, but at least gives us the flexibility to adjust language on referrals.
Sean, I can jump in really quick. So from a communication standpoint, Charlie, I think that when we have our SBM, we will be able to tailor the messaging substantially And especially in the notices, we'll be able to tailor that messaging. So we will be able to send out much more customized messaging and make sure that the messaging is much more clear and provide more guidance to help folks understand kind of these changes and the interim process and give them more guidance on what to do and kind of hold their hands a little bit more because it's definitely a confusing process. And unfortunately, the eligibility notices that healthcare.gov sends out right now are very cut and dry, and there's not a lot of guidance on what to do in the meantime.
Kind of to that effort, I think I presented this back in the April meeting, but we just added language to the OHP notice whenever it comes through the federal marketplace as like the application source. We have a thing that tells them to go return and report their OHP approval or OHP bridge approval back to the marketplace. So we're working on improving the interaction between those things on our notices as well. But until we have the marketplace system to, that's the main place they're seeing this communication currently at that stage of when they applied and updated. They won't have heard from our side until we make the determination, unfortunately.
This is Lindsay Hopper. I was hoping to understand what you've learned from Minnesota and New York about how they handled this. Was this just something that was not an issue for them given their platforms, or did they have anything helpful to offer since they're for a long?
I don't know if we've looked into that. I'll have to check in with the rest of the team on there.
Perhaps there's something there because this is obviously not ideal for folks.
I believe New York has a state-based marketplace as well, and I can't remember the Minnesota options
I think
there.
Minnesota does too. I can't remember either, but I assume they might have something relevant to share here that they've considered. So that's what I was thinking. Because nope, it can't be that anyone wants this.
Any other questions on this one? Otherwise, let's move on to the annual income lower boundaries. So if we can go to the next slide, we have a new policy change that affects the income limits for OHP Bridge. So until now, OHP, or the one system, our eligibility system, has been approving anyone below 200% of the poverty level annually for OHP Bridge, including the members between 100 to 133% of the poverty level annually. So we had to update the system to add in a lower boundary. That is the policy as it always should have been, but unfortunately the one system was built incorrectly at launch. So after the updates, one should only be approving members for OHP Bridge who have monthly income above the 138% OHP plus limit and whose annual income is 133 to 200% of the poverty level. So there should be a lower boundary on the OHP Bridge program there. That leaves the 100 to 133% annual income group as should be headed to the marketplace instead. So to be affected by that, they have to be both above the 138% monthly limit for OHP and within that 100 to 133% group annually, which basically means this is people with variable incomes or who've only had their job for part of the year, where they're above the monthly limit for OHP plus, but below in that range annually. This kind of stems from how the Affordable Care Act regulations were written around the monthly versus annual income distinctions, and we can't use the funds that fund OHP Bridge for this group here. So basically the system is always going to first check for those monthly income programs and then proceed to consider their annual income. You can go to the next slide.
Real quick, do we know how many people that affected?
Just about 1,000. We were thinking it was going to be a higher number, 17 to 1,900, and it ended up being just over 1,000 people, with about 100 still in some step of resolution on they're getting requests for information and whatnot to make a final determination on there. So 1,000 to 1,100 range.
And are you considering a retro adjustment, or is this just going to be going forward?
So
for those affected members, I should say.
I think I've got this on the next slide, but we've got a June update that blocked any new enrollments, and then the data run last night went through the current members to see if they're still eligible. If we can go to the next slide, I'll cover what's happening next in a little bit more detail. So first off, this is how the annual income limits are going to stack up going forward. Um, Basically, we first consider your monthly income looking at the OHP Plus based programs based on monthly. Most OHP Plus programs are based on the monthly income first. If we deny you for all of those, we'll start looking at annual. If you're below the poverty level itself, 100% of the poverty level, that would qualify you for OHP Plus based on your annual income. If you're in that 100 to 133 group, there's a lower boundary for OHP Bridge, and they're below income for OHP Bridge and above income for OHP Plus in that situation. Both those reasons are going to be in their denial letter, so it's going to be fairly confusing to the member. OHP Bridge now has that lower boundary of 133% of the annual income going up to 200%, and then unchanged from before, if you're over 200% annually, you're over income for OHP Bridge. If we go to the next slide, this is how those charts stack up annually. If this is a useful way to look at it for folks, we're always first going to screen someone for their monthly income first, see if they qualify for the monthly programs, for instance, and then we would proceed to go to the annual step next, and then check to those different things, or those different thresholds there. So if we have someone with, for instance, 2,000 a month in monthly income, they've had their job for only 9 months of the calendar year though, and have 18,000 annually, we would first compare that $2,000 income to the single adult limit, see that they're over the income limit for OHP Plus based on that, and then compare their annual income to the annual limits below. So in many cases though, people who have a monthly income or an annual income that falls into this are going to qualify for one program or the other in the not too distant future. If their annual income of 100 to 133 was an ongoing consistent thing, they should qualify for OHP Plus monthly in some of those months. And similarly, if someone ends up in this group because of like a partial year of income, often in the following year, they will end up qualifying for OHP Bridge based on just this can only affect people with variable incomes by how those monthly versus annual definitions work out. Hopefully I feel like I explained that fairly confusingly, unfortunately. If we go to the next slide, we've got some more of the next steps that Stacey was asking about, though. So, as I kind of mentioned earlier, this was driven based on the funding regulations. We can't use the funding for OHP Bridge for people in this group due to how the ACA rules around monthly versus annual work out, and kind of assume the other population is covering this group. So we just applied the second step where we checked if all the current members were continue to be eligible. Thankfully, that was less than the 1,700 we were anticipating. It's down to just 1,015, plus the 100 or so that we're still deciding on. We need the member to respond and provide some information to make a determination on those other 100. Next step gets into what's happening to these members next. They are getting a notice in the mail that was sent yesterday that we can go to the next slide. They're getting a notice that was sent yesterday that their benefits are ending on July 31st. They don't have a whole lot of advance notice on this, unfortunately, but they're going to need to take two steps. First of which is reviewing the information in the notice and telling us if that is correct. If either their monthly or annual income has changed, that may well qualify them for either OHP based on the monthly or OHP Bridge based on annual having risen back into the eligible range. So their income between when the determination was made back in 2024 may vary from what's happening in 2025. If they now have a full year of income now or something like that, that might put them back into being eligible. Reporting changes or reapplying is going to be the move for them if they have those changes. Otherwise, if they aren't going to be eligible for one of the programs again, applying for the marketplace would be their next step. If they're able to complete that process by the end of this month, then they would end up on marketplace coverage starting the day after their OHP Bridge ends. Otherwise, they're going to get a special enrollment period based on the loss of coverage, as well as they're still able to use the under 150% special enrollment period, or under 150% of the poverty level special enrollment period on the marketplace. So they're going to be able to get into the marketplace outside of normal open enrollment season. And this group should also qualify for pretty significant tax credits and cost sharing reductions if they picked a silver plan. If we can go to the next slide. So there's a few possible outcomes here for members. Default one is that they're for the 1,000 affected members here is that they're no longer to be eligible for benefits and their application is going to be referred to the marketplace. That does mean that they do need to take action to complete the marketplace enrollment process, sign all the agreements, select a plan, and whatnot. So action is still required for them to make it over to the marketplace. Otherwise, there's a subset of these members who are going to report changes that move them to OHP, either based on their annual income below 100% of the poverty level, monthly income below 138% of the poverty level, or some of them will have changes to report, such as pregnancy, which was basically we calculate the pregnancy as an extra person in the household, and that means the pregnancy income limits are going to be basically always higher than the OHP bridge ones. Otherwise, members who are reporting changes to us that make them eligible for OHP Bridge again are often going to have a 1 month gap in coverage. That's due to the start date rules I referenced at the beginning, where a change reported in the second half of the month is going to end up being treated as a new application and give them a September 1st start date. Members in that situation may want to consider enrolling in the marketplace for 1 month in order to stay covered and then move back to the OHP and then tell the marketplace that they have OHP Bridge on whatever their start date gets reassigned as, likely September 1st if they're doing this action in July through the first half of August, and then closing their marketplace out once they move back to OHP or OHP Bridge. So that is due to the one system not allowing change reports while it's in closure mode. It's just a feature of the system, unfortunately, where it does not, once the case has been scheduled for closure, anything new coming in is treated as a new application.
Sean, if I can jump in just really quick, from a marketplace side, we are going to be doing some communications out proactively to try to help some folks with transition. So the OHP side is doing some text messaging and things. We are also going to be doing some direct text messaging and emails and sending letters to folks that let folks know that they can come on over to the marketplace and that we're happy to help them. The text messages will start and the emails and everything will start next week. We will also be doing some kind of more generic social media posts about losing coverage. We're not going to be calling out this issue specifically, but you will see some social media posts about if you've lost coverage recently or if you're losing coverage, this is what you need to know. We're also going to be pumping out some newsletter content to our insurance agents to make sure they're aware of the issue and giving them some guidance, as well as giving some updates and some partner meetings that we have upcoming in our marketplace connections. So I just wanted to let you all know that we are working very hard to make sure that from a marketplace side of things that we are letting folks know of their options as much as we can to try and get them into new coverage as quick as possible.
Thanks, Amy. It looks like Joanne has her hand up and then I'll follow.
I do, thank you. I have two questions. One is, if I have OHP, am I getting it from any other source other than the marketplace? I.e., would I get lost in any of this documentation or reach out if I wasn't using the marketplace to sign up? And my second question is, how are you, I heard you say insurance companies, but how are you letting providers know that this could be an issue from August 1st to the end of September?
I'm sorry, can you repeat your first question?
We're talking about people who are getting their Oregon Health Plan off of the marketplace, and I wasn't clear. Is there another way for me to sign up for Oregon Health Plan if I'm not on the marketplace? Or is that the only way I can get OHP is through the marketplace?
We use a different eligibility system than the marketplace does. They're pretty much separate from each other. They do send applications back and forth to each other, but they're through almost all members get OHP through the one eligibility system. So it's going to be a separate system there. There are some in child welfare who use a slightly different system, legacy system, that are slowly getting ported over. But most people are going to get that through a separate system from the marketplace. They can apply through the marketplace and get their application sent to us. though, which is what the marketplace will do when they think they're eligible for OHP Bridge. Does
I
that
see.
address the question?
I think so. I'm just curious if there's another way for people to understand, to be communicated with. Amy is saying we're going to send out these notices and these letters, and so if I'm not on the marketplace, which is what I think you're saying, is there are other ways that those folks will learn that this is happening.
Yeah, the
Oh,
one system's going to send them the eligibility notice, and then we will also text from our system and are going to be passing the data to the marketplace so they can help do some outreach as well.
yeah. To clarify, the primary communication about the issue is going to be coming from the OHP Bridge side of things, or the one system. We're from the marketplace side, we're getting a list of all of the affected members so that we can do some additional direct outreach to try to help them ease the stress and and find new coverage so that they're not feeling so, lost and in the world alone. So that's kind of the plan. Yeah. Sorry for the confusion.
And to your provider communications questions, we don't have a lot of direct provider communications going out. We do have some going to the assister network and whatnot. So the eligibility folks within those providers potentially are getting this. The primary system that providers use to identify whether or not someone has coverage is like a real-time eligibility verification thing built into their electronic medical records. That should tell them about the coverage changes that are happening for that member and whether it's active or not still. There's a fairly limited subset of this members that are affected, and it's unfortunately an incredibly technical issue to fall into this gap. So
yeah, I'm concerned it will still be very confusing for them. Can you share a little bit more about the way this issue was identified? Was it in a QA process? Was it how did the configuration and processing issues come to light?
I don't quite have the answer to how it was identified. I know that the system was built incorrectly, and then once that error was identified, we needed to take steps to correct that going forward to protect the trust fund integrity and all that.
Sure.
We can try to return an answer exactly on how that was identified for you.
I think I'm both curious, and also this is a fairly long time for this to have been running in this way. And so I'm curious about what that means for QA and what you take from that moving forward to what we will take from that moving forward to the marketplace transition and how that informs what should happen with QA. So I think that would be a great follow-up if you're able to share, if someone is at a future meeting, please.
We'll try to report back.
Great. And it looks like, you've got your hand up. I'm going to lower mine.
Yes, can you just confirm this is for July 15 to July 31st, 2025 this year?
Yeah, the notices just went out in the mail. It turned out being the 16th that they're put in the mail, but then their closure date for OHP Bridge will be the 31st.
Well,
And then
but Sean, by human nature, they will not be responded by July 31st. You have any grace period for those people at all?
Unfortunately not. We had to take steps to protect the trust fund and correct the issue as soon as identified to protect the program integrity as a whole.
Okay. But this is very confusing though, and I'm trying to find a way to help the consumer, even though I'm not, I do help some of the OHP who walk into my office, but oh well. And another question is, how do you verify their income? What system are you using? Is it quite accurate?
So the one system does try to verify off certain data sources, but the members provided information is going to be the primary way that we identify income. They are required to keep us up to date about any changes in income. So if their monthly income has changed and they should move to OHP Plus based on that, it's the member's responsibility to be telling us most of those changes, though we do verify off of a federal data hub that Medicaid programs use to
Well, I don't
make
mean
sure
to
it's reflected.
be I don't mean to be negative, but doing this will make people lose coverage for, more, and I think that's missed the purpose for us trying to do this at all. That's just my comment, but I will try to help to communicate with the consumer. All right, thank you.
An unfortunate change. And one of the things that we didn't mention in the slides yet is we did manage to communicate out lists of affected members to their OHP assisters when they have them to try to both update that income, hopefully in advance of this actually taking effect. So some of the reduction in the members we expected might be from that. Otherwise, they should also be able to hopefully help them get to the marketplace either themselves or by referring to a broker in their area. that was only a minority of the affected members. About 300 of them had an assister. Neshoba. Oh, sorry.
Hey, Sean, thanks. So yeah, I just wanted to kind of represent the community partner side, right, as an assister agency, and just kind of the consumer experience, just to kind of just add a layer of complexity to an already complex situation, of course. But we did already actually just get our list this morning of affected members. And a lot of community partners have, been banding together to kind of make sense and come up with a protocol. The thing that I was going to highlight is that what's really integral for consumers going on to Marketplace is indicating, right, that they have had a Medicaid denial, right? It is not enough to just list income, because if you just list income, you're going to be stuck in a loop. Your income is going to be initially determined as OHP eligible. You're going to be sent to OHP. You're going to get a denial, right? And you get stuck in this potential loop that we've seen a few folks get stuck in. So it's really important, right, that we educate our folks about the Medicaid denials. That is really integral for this step. We've seen a few folks kind of stuck in this loop and have had to get in directly. And yeah, it's unfortunate, but I think for one, as an opinion, I'm really looking forward to the Marketplace transition, our state-based Marketplace transition, to try to ease some of this. But for now, it's really education-based and starts here in this group. So thanks, everyone.
Neshoba, I just want to say thank you for bringing that up and just bringing to light again that loop issue, because I know that's been an ongoing issue for years. And I will make sure that in our upcoming partner communications in August that we address that to make sure that our partners are reminded how to avoid that issue going forward. Thank you.
Like Charlie's got his hand up.
Yeah. So you may have said this already, but how many people are affected by this?
1,015 are definitely losing coverage. Then we've got about another 100 where the mass update wasn't able to fully process, and they're going to get a request for information to confirm whether or not they should be affected, or some piece of information is going to be verified with the member and need a response on those other ones.
Okay.
So there's kind of in process of decision for another 100.
And how long do we know how long those people have been covered? Like they just been going along thinking that they have coverage for a while, and now they're just gonna find out that, like, basically when they get the letter,
Yes.
like tomorrow, they lose coverage?
Yes, potentially up to a year. It could also be some members who we blocked new enrollments in June, so none since then, but it could be people with fairly short blip on OHP Bridge as well.
Wow, that's really bad.
Don't disagree.
I don't see any more hands right now, Sean, if you want to.
Well, I just, sorry, Lindsay, I didn't raise my hand, but I wanted to, it was Lindsay's earlier comment about how it was identified. I think that is important to understand. And also, I mean, her question, I didn't hear it answered all the way, Sean, was what steps are being taken to ensure that it doesn't happen again, just to make sure that we're doing our due diligence and learning from these things when they happen. And you don't have to answer me now, but that might be a nice follow-up for later.
Yeah, I'm not involved in the technical parts myself, so I'll have to confer with the folks who do, and we'll get an answer back for you.
Like Joanne has her hand up.
Thank you, Joanne here. Yes, of those 15-ish 100 people, do we have a breakdown by county? Is it heavy in any particular county?
We don't have that data back yet. We are getting the request list to attach that sort of data to it, submitted hopefully today, so we'll have that soon, but don't have that quite back yet. It's only 1,000 or so that are losing coverage, though. The 1,500 was the coverage gap letter that we'll be sending people to. So it was expected to be 1,700 initially, so then it was much lower than we expected yesterday, so we're writing off at least that good news.
All right. right, I'd say keep going, Sean, and folks,
Alrighty.
raise your hand if you have questions on future slides here.
And we have one more smaller issue to share, which is a effort to clean up mismatches in health coverage. So this is not a like mass batch of disenrollments or anything like that. This is the beginning of ongoing efforts to kind of clean up data between our systems. So we've identified about 1,500 members who have OHP Bridge without other health insurance listed in the one eligibility system, but who do have other health insurance listed in our billing system. Unfortunately, the two systems take about 2.5 months to pass data between each other right now, so it's a very slow process that we're trying to improve just across the board. But for OHP Bridge specifically, this is relevant because OHP Bridge members can't have other affordable health insurance. So that follows the same rules as the marketplace uses. Eligibility for OHP Bridge generally follows a lot of the same categories there. So the 9.02% affordability test needs to be run for those members. But because the pass between these systems is not perfect by any means, we are not certain whether this is actually active coverage. So trying to figure that out is going to be the first step here. This process is going to take us months, and it's going to be an ongoing basis as new ones are identified. So this is just the kind of the start of ongoing cleanup efforts that's going to be happening, where we'll have a member or the worker reach out to the member by phone to try to verify that information first. Then if they don't manage to make contact with them in a couple of attempts, proceed to send them a written request for information, asking for that other health insurance information. And if the response is not received, they would get a closure notice based on not responding. We go to the next slide. Goals of this are, one of the main things is going to be just removing outdated policies. We expect quite a few of these are just outdated information in the billing system from having coverage with private coverage on file at some point in the past that just never got updated. On their last application, these people did not indicate they had other health insurance, so that makes us suspect a lot of these are just outdated information to remove, but we need to verify that. If it is valid coverage, we need to get that added to the one system, though. That way it can run that employer coverage affordability test for the OHP Bridge members. If they do have affordable coverage through an employer, they shouldn't have ended up with OHP Bridge, and that was an inaccurate determination, essentially, and will end benefits if that's the case. Same goes if they have Medicare, where OHP Bridge members can't have Medicare. So for partners and members, this is going to be hopefully pretty simple because most of the work is being performed by those eligibility workers actively making the calls. Otherwise, it's going to follow our normal request for information process for members where they're asked to provide their other health insurance information. We also want to make sure partners and members pay particular attention to entering that other health insurance through an employer and whatnot into the one system if that's available to them. That way the one system can run those calculations now, because that's a new feature that rolled out with OHP Bridge launch. The one system previously wasn't needing to do those marketplace or those calculations that have previously only been relevant to the marketplace. So if we can go to the next slide. Flowchart here is going to start in the upper left. Once we identify someone who has other health coverage information on file in MMIS, we're going to reach out to those members and then send them the request for information if they don't respond. If they don't respond at all, they would follow the left path in orange and close for non-response. If they do respond, though, we're first going to determine whether or not that coverage is still active at all. If it's not, we're going to remove outdated coverage and their OHP Bridge will continue with the accurate information we're cleaned up. And so it doesn't cause any billing issues and whatnot on the MMIS side, which is our billing system. Sorry to use the acronym. Otherwise, if it is still active, we need to figure out if it's both employer-sponsored and affordable. If it meets both those requirements, then their bridge would end due to having affordable employer coverage. If it doesn't meet one of those, then their OHP Bridge could continue with the accurate private coverage information on file. So that's basically going to be how the process is going to work. That does get at least to a state where we have cleaned up data. Some of these might end up being marketplace plans where we identify overlaps and we'll want to reach out to them after that. So wanted to mention that portion of it to you, though we don't have a specific plan for if someone is on marketplace coverage, what we'll be doing with those, and are looking forward to having cleaned up data so we can proceed with what to do with that. Otherwise, this one should be a smaller effort. It's basically just the start of ongoing cleanup operations for OHP Bridge there. So we will have some members losing coverage as a result of that or getting notices in the mail, but this should be a hopefully less significant one than the other two. Otherwise, that should be the end of our updates for OHP Bridge today. Any last questions?
Yeah, sorry, this is Lindsay. You said 2.5 months is the lag time on the reconciliation running.
Currently, it's a very small team working the
So it's fully
import
manual.
queues. Sorry,
Fully manual reconciliation. It's
pretty
not.
much.
Okay. Is that is the cleanup involving tightening that up, or is the cleanup trying to get current but not adjust the timeline moving forward? Can you speak to that at all?
This effort's cleaning up the data where we have identified mismatches coming
Right.
from that system.
But
we
going
are
back a certain amount of time, I assume, and then there's always a rolling risk, right, of mismatches?
yes, and we will continue going through this process as new rolling mismatches are identified so this will be the process for resolving TPL mismatches going forward
But
the
how
expectation.
old is this backlog, I guess, is what I'm trying to understand. Maybe I misheard that.
So we hadn't been performing any of the cleanup operations since OHP Bridge launch. So it goes back to OHP Bridge launching back in July of 2024.
Okay. So the goal is to get to what level of service level timeliness on reconciliation? Does that make sense?
I'm sorry, I'm not understanding the question.
Well, if we're this far back, right? So going back to launch, I understand, but what's the goal for timeliness of cleanup moving forward? Is
I'm
it
sure I know the specific time frame they're aiming for, but it's going to be happening on an ongoing basis. So I don't know. I'll have to return an answer on how quickly they plan to flag these on an ongoing basis.
okay? Thanks. It looks like Charlie's got his hand up.
Yeah, sorry, I'm still stuck on the last piece. And I guess I'm trying to wrap my head around it, and I tell me if this is accurate. The the donut hole, I guess you'd say, for the 100 to 133 annual income, but over 138. That's only something that's going to affect people who, like, in terms of people losing coverage really unexpectedly, only people who are uh, incorrectly put into a program in the past. Like, is that correct? Like, so going forward, I know at least with OHP, we have 2-year continuous eligibility. So, like, when that 2-year comes up, then someone is going to have to, um, then maybe they lose their coverage at the end of that period. But going forward, there's not going to be a situation where someone who goes over like 139% FPL in a month gets pushed into marketplace and then back to OHP Bridge or OHP. Am I understanding it correctly?
Yeah, these are mistaken determinations. So normally with OHP, we have continuous eligibility for 2 years that offers both financial and non-financial change protections, but not any protections against erroneous approvals and things like that. OHP Bridge has similar rules, which we call the 12-month coverage period, that only protect against income changes. So if they rose out of that range, they wouldn't lose benefits on that basis. This is kind of the system was designed incorrectly from the get-go. We needed to make corrections to that. These were erroneous approvals. They shouldn't have been approved for OHP Bridge if we had the system designed.
Got it. Okay, yeah. So I guess that's what I was. Thank you for clarifying that. So going forward, so a situation like this, assuming we don't have other mistakes made in the future, won't occur. Those people will just be denied to begin
and sent to the marketplace
and then they'll
immediately
go to
rather
marketplace. Yeah.
yeah.
Okay. Thank you.
Thanks, Charlie. Thanks, Sean. Sean, this is your last slide, yeah?
Yes.
Okay. Any other questions for Sean or Amy? Okay. Next topic is state-based marketplace of a theme connecting to some feedback folks just shared.
All right. Hello, Dorosina Mardashev. I am the project manager for the state-based marketplace. And today we're just going to cover our standard topics with you. A few of them are common topics we share with throughout these meetings. So first one, we're just going to go over the overall project timeline. We're going to cover project accomplishments that have been completed since the last time we have met back in April. And then we'll also share the implementation timeline. We'll give a procurement update, a CMS blueprint update, and then just a reminder, a slide of any upcoming partner engagements, and then what's next. Next slide, please. So here, there are no new changes to the timeline. We still continue to work towards completing our contract negotiations by end of July of 2025. So we have 2 weeks away, and we're looking in pretty good shape to meet that timeline. As we're working through those negotiations, we also are completing our stage gate 3 activities, which are implementation activities, planning activities for us to make sure we're prepared for starting the execution of the implementation piece of the project. And once we get that, we'll be able to execute the project. Any questions on this? All right, let's move to our next slide, which is accomplishments. So we've continued to have our IQMS vendor, our independent quality management services vendor, Blue Crane. They are providing oversight on this project, ensuring we're following standard practices. So we receive on a quarterly and monthly basis status reports. So we got our approval for, we received a deliverable that we approved on April 29th, a quarterly status report. I just wanted to let you know that it was reported low risk and green status. So great report there for us. And then May 12th, we have completed the branding name options activities that AIM is leading and working on branding. We also have completed, approved the IQMS monthly status report. Again, it was low risk, green status on May 21st. June 21st, we received a deliverable from our IQMS vendor for the task that they will be, for the deliverables that they will be reviewing from a quality perspective for the, from the solution vendor. And so we have a quality checklist, some standards that we must abide by to make sure that we're producing good quality products, deliverables. So we approved that checklist. On June 20th, we have the Blue Crane vendor went ahead and looked at our project management plans, our benefits management plan, the organizational change management plan, our schedule scope, just looking at all of our quality of product for managing the tools that we're using to manage the project, our processes. They reviewed all of our artifacts and provided some feedback. We approved that deliverable with their feedback and made adjustments to our plans to tighten up our processes and make sure everything was a good quality deliverable. On June 24th is the, we went ahead and got another monthly report. And again, this was low risk and green status across the board. June 27th, the team has submitted the initial blueprint draft. It was submitted to CMS. Just wanted to give a huge shout out for the team. CMS actually requested this blueprint draft to be sent over by August 2025. The team has overachieved and we submitted it in June. So great job, team, on that. And 3 more branding related. A creative concept deliverable was completed. Creative concept development was completed. And then we also have, within the contract, the procurement, we have completed the statement of work, negotiating all the deliverables, the scope of work, and so on. Though the content of the statement of work has been negotiated. So that was done back on July 3rd. That's just a component as part of the contract negotiations deliverables that would be included as an exhibit. And then baselining our project management plan. These are all our processes. We have to as part of standard practices, we maintain our processes, keep them up to date on how to handle the project. So before we go into initiation to implementation, our oversight analyst within EIS has been reviewing them and getting them approved. That's what we have accomplished since April, some big milestones. Any questions on the project accomplishments? All right, implementation timeline. The implementation timeline, as mentioned, there's the CMS Exchange blueprint here. This is, it's been done. So our initial timeline was let's get it done by August, but the team has overachieved and got that done back in June. So that is in blue. And one thing to note, just looking ahead, the engagement with CMS, it really begins in August of 2025. So there has been some engagement, but the engagement really starts with CMS in August. And another detail I'd wanted to share, as we're going through these work streams, you can see the CMS Connect. We're going to onboard the solution vendor. We're going to work closely with them, and we're going to have a more detailed budget and schedule for us to baseline and to be able to show our progress as we are moving forward through the implementation and closing activities. So that is an activity that we'll do when we have an executed contract and a vendor, and we'll work with them to build out those deliverables. So that is something that is planned for. At this point, this timeline is pretty high level. And once we get through that task of building out the schedule, I'm sure this implementation timeline will be adjusted a bit, but this is our preliminary estimate of what we're anticipating the timeline to be. Another detail I wanted to share here was just want to say thanks for the strong support from the legislator. We did secure approval for a funding limitation request and new staff positions. These positions are going to be essential in helping us move forward in the implementation, working with the vendor, specifically managing large-scale activities required by CMS. We also will be, supporting the implementation tasks with the service provider, and then we also will be focusing on the training program for the community partners and the insurance agents. So these folks will be involved in that. This puts, and then, we really want to put together a very comprehensive training program for our community partners and insurance agents. So these additional resources will assist in that. By getting the approval of the funding limitation and also the new staff position, this really puts us in a good position for the work ahead. Any questions on this timeline? All right, next slide, please. And I will hand the baton over to Victor.
Thanks, Dorosita. Hi, everyone. Good to see you and hear you virtually again. Victor Garcia, Operations Advisor and Program Liaison with the Marketplace and Business Lead for the project. My pronouns are he, him, and they at your option. It's just a quick update on our procurement. Has been going well. Our single point of contact for all questions, specifically regarding the contracting process and anything related to our RFP, is Julie Curry. She's with DAS Procurement. She's our procurement officer. Has been one of many of our just awesome partners that have kept pace with us as we've tried to execute this on a timeline that's not ordinary state government timeline for this sort of thing. Any specific questions that we can't address about the procurement are referred to her. So on our timeline, as you can see, we started in February, our RFP process sort of ended or culminated in February, where we awarded to a vendor on February 14th, and then finished responding to protests on April 15th. That all means we didn't actually start negotiating with the vendor on our contract until after that. So it was really kind of beginning of May when things kicked off. So between then and now, we're hoping to complete our contract negotiations by the end of this month. We have been shooting for June, and with our original timeline, that would have been more than achievable, but with the delays we experienced, it was a little too aggressive to get everything done properly. So we are making sure that we do kind of dot all the I's, cross all the T's, and our vendor wants to do the same. Things are looking good though for hitting that July mark. We're hopefully wrapping things up here pretty quick. But again, trying to make sure we don't miss anything. So in our effort to do this quickly, we don't want to do it improperly. And then once we execute the contract and begin phase 2 implementation, we can really start doing the actual work that isn't talking about all the words that tell us what'll happen if bad things happen. So we're excited about starting stuff that isn't related to RFP and contracting and doing our actual SBM stuff. So in the meantime, we are where we're at, but it's looking good for executing by the end of this month. And of course, everybody will know about it as soon as we do. So any questions on that or how that's going at the moment? Okay, thanks. And I will add, we've also been, there's been annual meetings with the carriers. We've been kind of hopefully letting them know as well, the insurance carriers, we're expecting to get started on this as quickly as possible. And they're very important partners in this with us. So I appreciate their patience as we try to get to a place where we can start getting them the details that they really need before we start executing our implementation next year. Next slide, please.
Hey, Victor, this is Zach from the Regents, Zach Olson from the Regents and Bridgespan Plans. Do we have a date that you anticipate will be engaging with for carriers to engage with the vendor to engage with Get Insured or OHIM and Get Insured around this, given the imminent contract signing date?
As soon as we have the executed contract, we'll get together with the contractor and see when those kickoff meetings can be scheduled. So we still need the schedule, but we can't really formally engage in any of that with them until that's executed. So
sure. No, and I understand that's been the way all summer. Do you have a anticipated date?
Not at the moment. I would imagine sometime in hopefully the later part of calendar Q3, so September, but it's hard to say at this point because it depends on what steps need to happen first. So that's my hope. Definitely,
I appreciate the September. I appreciate the September guess. Yeah.
The sooner the better, but everybody's doing stuff kind of, there's this thing happening from November 1st to December 15th or December 31st, open enrollment. So we're trying to, everybody running up to that also has important stuff on their schedule. So we're trying to make sure that's balanced, but it'll definitely have to be before then. So once we execute though, we'll let everyone know.
Thank you, sir.
So this is part of that, part of what we're doing with executing our contract and communicating with the carriers and preparing for all of the things we're going to do next year. Dorcita mentioned our blueprint application was submitted. The CMS blueprint for state-based marketplaces is a way that marketplaces communicate with CMS about their responsibilities being a state-based marketplace. The marketplace currently has a blueprint in place for being an SBM-FP for using the federal platform while still being a state-based marketplace. And the blueprint itself is really sort of an explanation of sorts, but also a checklist slash accountability tracker for CMS because there are various state structures. For SBMs and how they work and how they integrate with their Medicaid system. So in some states, the marketplace is together with the Medicaid system in a single eligibility system and enrollment platform. In other states like ours, they're going to be separate. So the blueprint in part kind of asks, how are you going to do all of the important things, covers system security plan. So with all of the abilities we'll have as an SBM that we're excited about, we will also have new responsibilities that we don't currently have because we will be in charge of more things. So the blueprint kind of covers how we plan to address those things, how we plan to have a consumer assistance center when we don't have one right now. It's at healthcare.gov, or we have one, but it's not designed to handle the volume that healthcare.gov handles for us right now as an enrollment platform. Things like that, system security, it's pretty comprehensive. If you follow the link, you can see kind of what it looks like. So So it's again a formal application to let them know we are changing our structure and to give them notice well in advance, so that it also kind of kicks off a project oversight for them, because there's things we have to comply with and then they have to check to make sure we have complied with. So our initial application that we've submitted is a lot of attestations at the moment. It's saying we will have this in place by this time, or we plan to do this way. And it is a living document with CMS. So as we go and we complete those steps, we also update those things to say it is now done this way. So right now it's a lot of anticipation, a lot of dates planned, and then when the vendor comes on board and those dominoes start falling, we check them off on the blueprint. In part, what it does demonstrates our legal authority, government's like the whole scope of what we're doing with respect to CMS oversight, and how we plan on doing the various aspects of that. So the consumer assistance, the conducting eligibility and enrollment, how we plan to communicate with Medicaid, which of us does the determinations and which of us notifies consumers. We have to explain all of that between us and the one system, who's doing what and how our relationship works. All of those sorts of things are covered in there. So the key components of our specific blueprint application, we have a legal framework for under, well, SB1 created the marketplace, and Oregon chapter, the statutes, chapter 741, that's our marketplace statutes. And for our state-run website, the call center, partner programs and outreach programs are all kind of also covered in the blueprint. I mentioned the integrated eligibility and complying with ACA, that's part of the one system communication. And then our certification of qualified health plans, we actually do that right now. And so how it happens will be a little different with the new system, but ultimately it will be the same process. It'll just be ours instead of living with healthcare.gov. And then, of course, one of the most important aspects is how we plan to conduct privacy and security audits and stay in compliance with the requirements for all state marketplaces, governed by right now something called MARS-E, which is a set of security protocols that we have to not only attest to, but also have sort of audited and tested and provide evidence that we've done all that. So over time, the blueprint gets a lot of stuff added to it, documentation and everything to support the attestations and the attainment of what we've attested to until we get to about this time next year, when there will be an operational readiness assessment conducted by CMS based on what we've given them in the blueprint. And that's why they require at least 15 months prior to the first open enrollment period. So they said that would be August for us. And again, we tried to get that done a little earlier, especially since a lot of it's attestations, just to make our intentions clear, to get that process started with CMS earlier, to make sure we're having those conversations, that they know we're serious and we're getting into it and we plan on doing, this next year. We've already been talking to them, but the blueprint really confirms it, that says we're doing this now. And then conditional approval, which is what we're getting now, will lead to that full approval again, hopefully next year when we demonstrate our operational readiness. At the moment, everything looks like it's going according to timelines that are a little bit better than a lot of other peer states have had in terms of just amount of time that we have. So we're getting a little bit earlier start. More time is always better. It would have been better if we could have started earlier, but we're still in really good shape in terms of being able to get all this done in the time we said that it would take to get done. So, so far, no concerns there, at least from our perspective, again, compared to what we've seen in other states. And so this, again, little quick overview of the blueprint application, part of the process, but also a really good mechanism for CMS to kind of stay in step with what we're doing, kind of on a month-to-month or week-to-week basis when it gets there. And again, that sort of final green light, like go, no go, will be partly their assessment in the coming summer. So it is a sort of fail-safe. If things aren't quite ready to go, there is that sort of stop button that can still pivot to the federal platform if needed. It's not something we expect to happen at all, but it is there again as a fail-safe for anyone who may be concerned. What happens if you don't? it's not great, but there's still healthcare.gov. Nothing, people still enroll in plans. No interruptions from the customer's perspective. It'll just be kind of, again, that mitigation, but very slim chance of anything like that happening again, at least based on everything we're seeing right now. Any questions on Blueprint?
Victor, it's Zach from Regents of Brisbane. Again, I appreciate the transparency on the behalf of OHIM on this. This is great. And we're completely with you, of course. As far as a carrier perspective, it would be awesome to know the first, well, like a target date that we could start testing with you guys next year, right? To make sure that the infrastructure and all the pipeline for sending A34 transactions, etc., is good. So, and I know we don't have that as part of this presentation, but that's kind of what we're driving to is when can we start testing with you guys? So if you can put that on your back burner and something to provide to the carrier teams, that would be awesome. Thank you so much for the transparency again.
Sure. Okay, thanks. Next slide, please. And then upcoming partner engagements, you'll have seen this a few times before. Got project newsletter and partner listening sessions monthly, the quarterly written updates to the legislature. Industry communications meetings happen jointly with our partners at DCBS, and we have updates in the agent and community partner newsletter, the marketplace monthly updates, and those happen monthly. And then our tribal engagement outreach as needed, ad hoc, as we're able, and there are events that we can attend or things that we're asked to attend, and all of the upcoming dates for those. Next slide. Okay, and then
Would you like me to take this one, Victor?
if that. I can, I just wasn't, okay, yeah, go ahead. I wasn't sure who was on deck. I can do that either way.
So obtaining stage gate 3 endorsement, for us to actually get that endorsement, we need to complete our contract negotiations, get the contract executed. Then we also need to get our budget estimate, which we're in the works on. All of these are in progress. But finalize our budget 10%, schedule 10% estimate, our scope statement 10% estimate, and crowd workbook. Once those are done, we will be able to go into the execution phase, which is where we will begin our implementation activities. And then in parallel, we continue to work on brand name and creative concept finalization. And then also Blue Crane continues to provide oversight on our project management practices and looking for risks and issues as throughout the project. So they will continue to produce our monthly and quarterly status reports. And I think this is our last slide. Does anyone have any questions for us?
I'm not seeing any hands. Thank you for the update.
Thank you.
We are running a little behind, but I wanted to make sure we call for public comment. Is there anyone signed up?
No, there isn't.
Thanks, Dawn. Anyone who wants to raise their hand as a member of the public to provide some feedback? Just looking at the participant list. Wait for it. Okay. I see your hand.
Yeah, I do. I just want to make a comment as on behalf of the consumer. I hope that on the OHP bridge to request a start date to retro back could be an easy communication. I don't know how the consumer will reach out. Is it by phone only, or could be by text or by email? Yesterday, I happened to have a walk-in client, OHP, and she received a letter and I said call back, but there is no one answered the phone call. We tried the 1-800 number and also a DHS in Yamhill County, but there's no one answered. So I just hope that it will be a lot easier process for the, what I want to say, the consumer to request that started. And, we really need to do clarify on the communications, either on the, request started and give them the instruction to tell them to go back to your doctor to rebill. And, another one again on to that Amy's are doing the best to try to communicate on annual income lower limit that people going to lose the Oregon Helpline Bridge by the end of this month. Thank you.
Thanks for your comment. I think what we'll plan to do is this section on the affordability final rule overview, and I think we're going to need to shorten the break, folks. I'm sorry, but good feedback here. Please take it away on the final rule.
Good morning. My name is Anthony Behrens. I'm Senior Policy Advisor with the Marketplace. I'm here to talk to you about the dangerous and exciting world of the CMS Final Program Integrity and Affordability Rule. The meeting before last, I talked to you about the proposed rule, was similarly dangerous and exciting. I'm going to try to zip through these slides because you are a little behind and I want you to enjoy a break. But please feel free to jump in on your mic if you have questions. All right, so let's see. We need to go back to the overview slide, please. Thank you. So the rule was officially finalized on June 25th of this year. In general, most of the rules were finalized as proposed. Some changes to the effective dates or the exchange type applicability were made, however. CMS received over 26,000 comments. This was a very short comment period, less than 30 days. So a lot of people hated these rules. Next slide, please. The rules essentially fit into four main categories: reduced affordability of healthcare, reduced benefits, limits on enrollment, and increased administrative hurdles and narrowed eligibility. So delving into the first bucket, we look at the first rule. So CMS changed the premium adjustment percentage. This affects the MOOP, the maximum out-of-pocket amount consumers will pay, and the amount paid towards premiums after APTC, and the required employer contribution for affordability of coverage determinations. CMS finalized this rule as it was proposed. The change will increase the premium considered affordable for employer plans, silver plans, and reduce the APTC. Manat has estimated that the MOOP will increase by about 15% and over what they are now, and that premiums for people eligible for cost sharing reductions will increase by as much as 4.5%. Next rule under this category allows carriers to offer less generous plans, so it changes the AV requirements. Biggest changes are basically widening of the range to a +2, -4 percentage points for individual and small group silver plans, +1 and ± for silver cost sharing reduction plans. So for example, a silver plan could now have an actuarial value of 66% instead of 70%, still qualify as a silver plan. This will enable issuers to offer plans with lower premiums, but would also decrease the APTC people receive, leading to a net premium increase. However, in Oregon, premiums are generally driven by network. So decreasing AV is not an automatic decrease in premiums. For example, in Portland area, one carrier is offering a 2026 silver plan with an AV of 66.75%, but it is the fourth cheapest silver plan. Lowest cost silver plan has an AV of 71.72%. And the last rule in this category imposes a $5 minimum payment on $0 premium plans so that people with APTC are prohibited essentially from auto enrollment. The rule was adopted as proposed and will take effect for plan year 2026. However, it was proposed with a sunset, so it ends at the end of plan year 2026. So it won't be effective in 2027, but the final reconciliation bill makes it permanent beginning for plan year 2028. And well, it actually ends auto re-enrollment for everyone in 2028. Everyone will have to return to the marketplace to verify information on their application and enroll in a health plan, even if nothing has changed. So one thing the rule does do is that it allows for an extended verification period beginning on August 1st. So that's a good thing, I guess. Next slide, please. So the next category is reduced benefits. So under this category, the final rule takes out gender affirming care from essential health benefits effective plan year 2026. It will still be required to be covered in Oregon, and how this rule will impact coverage in Oregon is still being determined. Marketplace is also working with DFR and DOJ to see if there's anything that can be done to prevent this rule from taking effect here. Next slide, please. Next category is rules that limit enrollment or impose administrative burdens. So the first rule under this category was a rule that was proposed to shorten open enrollment and standardize it from November 1st to December 15th. However, it was finalized to be no greater than to give basically SBM some flexibility. The rule requires that open enrollment be no greater than 9 weeks and must begin by November 1st. And that coverage has to be effective by January 1st. Changes take effect for plan year 2026. Instead of taking effect for plan year 2026, the changes will take effect plan year 2027. For plan year 2026, our open enrollment won't change. And then for 2027, we'll have to figure out what we want for an open enrollment period, as long as they meet those guidelines of 9 weeks, no later than November 1st, and effective coverage by January 1st. The next rule under this category was the elimination of what's called the low-income SEP. This was finalized for plan year 2026 only, so it sunsets at the end of December 31st, 2026. However, it should be noted that the final reconciliation bill prohibits premium tax credits for those who use this SEP and similar SEPs beginning in plan year 2026. So this effectively kills the SEP. Shouldn't necessarily impact a lot of Oregonians because people in this income range generally qualify for OHP Bridge. And the next bill in this category is the requirement that exchanges verify at least 75% of SEPs. So as proposed, the bill would have applied to state exchanges as well as FFMs and SBM FPs. As finalized, however, it only applies to FFMs and SBM FPs. So it will apply to us in the 2026 plan year, but then it will sunset at the end of 2026. So next slide, please. So we're continuing on this on this this category. And currently, so under the first one related to failure to reconcile, currently consumers have 2 years to file their taxes and reconcile their premium tax credits before they lose them. The final rule limits this to 1 year, beginning November 1st, 2025. Sunsets on December 31st, 2026. However, the reconciliation bill makes it permanent beginning plan year 2028. And the final rule under this category deals with data matching inconsistencies. So currently consumers can self-attest to income under the circumstances listed in the slide under 1 and 2. However, effective August 25th of this year, consumers will have to provide documentation and self-attestation will be prohibited. There is no sunset on this rule. Next slide, please. So the final category is narrowed eligibility. So the final rule effective August 2025, August 25th, 2025. The final rule prohibits DACA recipients from being eligible for marketplace coverage. The final reconciliation bill doesn't specifically mention DACA, but it effectively eliminates DACA eligibility as well. We're still waiting to hear if how healthcare.gov will implement this. Like, will they give coverage to the end of the month at least? That's our hope, but we don't know yet. Still waiting for word. Next rule under this category deals with premium payment thresholds. So under this final rule, insurers will no longer be allowed to waive the de minimis dollar amount that they used to allow to continue coverage. This rule is effective August 25th of this year, but it also sunsets December 31st of next year. And then the final one is past due premiums. So effective August 25th of this year, insurers will be able to non-renew coverage if a consumer owes past due premiums at the end of the year. There's no sunset on this rule. And that looks like the last slide. So, wow, that's pretty good. Does anyone have any questions that I can answer?
I'm looking at the box. So far, I'm not seeing.
Geez, I'm
looks
super
like
surprised.
Gladys has her
do you have
hand
a
up.
question?
Yes, thank you, Gladys Boutwell. I'm an insurance broker. Question on this last point, the allowance of coverage denials for past due premiums. So are they saying that, let's say that somebody owed a premium for November of 25, so they wouldn't be able to enroll for January of 26? And wouldn't the carrier just backdate the termination to October 31st since they didn't pay November?
I don't know what the carrier would do necessarily, but that's correct. If the consumer owes a past due premium, the carrier has a right to non-renew them for the next year. It was an amendment to the guaranteed issue protection.
Okay. But if the carrier back terminates them to October 31st because they didn't pay November, they can still not allow them to enroll again in January?
If they owe premiums at the end of the year, then their coverage the carrier can choose not to renew them for January.
So what I noticed on my end is that a lot of times on the marketplace side, it shows as though I use a third party, I use Health Sherpa. It shows premium due or premium past due, when I very well know that the client paid the premium. A lot of times I'll help them when we're doing their enrollment, some of the carriers, not all, but I know they've paid. but yet the marketplace still shows as though they're not paid. So how's the marketplace going to know if they do owe money or not owe money? Or is it going to be some delay where the file is sent to the carrier then comes back, and then how are we going to be notified that the carrier said no?
Yeah, so we haven't been given any specifics on how these rules will be implemented or work.
Okay, that's going to be an important one for brokers like and myself, because we need to know what to expect. So that way we can guide our clients as well as be notified, because nothing worse than them going to the provider in February, March, and then being told you have no coverage when they were under the assumption they may have been, or whatever. We would hope that they would know before then, but that doesn't always happen.
So as soon as we receive any information on implementation and specifics on how the rules are going to work, we will be reaching out to interested parties for sure.
And our broker's going to be advised on that first point on DACA, because I know I have a few DACA, but I didn't code them in any way. So I wouldn't even know to go back to those and say, hey, your coverage is going to end. Is somehow.
Yeah, we're not entirely sure how anyone's going to know who's DACA and who's not.
Okay.
But if we
Gladys, this is Chicky. Thank you, Anthony. So just we recognize your questions and your frustrations. Please know that we've raised many of these, if not all, identical questions and concerns with CMS and CSIO. We have not got any directions, especially since Healthcare DACA is also trying to figure out how to operationalize these new federal guidelines. So I know, like for DACA, the guideline is effective 60 days from posting. So that's already next month. So we know, we hear you. Unfortunately, we don't have any answers, especially since it's not our system, it's not our processes. We will share as soon as we know of any, but I also would recommend keeping an eye out, signing up for bulletins from CMS, SIO, for agents and community partners, because we probably will get the information at the same time.
Okay. All right.
So,
thank you.
I'm sorry, guys. We recognize, we know, we recognize the frustration because we share the same frustration.
Thank you.
I think it's Paul and then Joanne.
Yeah, and this might not be strictly for Anthony, but I've seen estimates of, 5 million, 10 million fewer marketplace customers nationwide as a result of this whole suite of policies. Do you know if there's any work on sort of sizing, what Oregon might face in their marketplace? Like certainly it's going to shrink, but do you know of any efforts to try and model that?
Specifically, so this is Chicky, specifically related to the program integrity rule. So Paul, I'm sorry, I'm going to have to disappoint you. We don't have estimates. We can't even make our best guesstimates because we don't have access to the data.
Okay.
So we can't tell you how many we probably had issues because of eligibility verifications from last year. Like we have no information aside from maybe we get once a year finding out who is enrolled and where they live. That's about as limited as we get.
Yeah. Thank you.
You're welcome. And I'm sorry, hopefully, again, this is one of the main reasons why we are pretty excited about our SBM transition, getting access to our data and being able to serve Oregonians at a much better level because we have access to the data. Joanne?
Yeah, this is Joanne. So I think this is the same question, but I want to ask it in my own personal way to see if I understand. We are estimating hundreds of uninsured Oregonians, thousands of uninsured Oregonians. Do you have a sense of what that might mean going forward?
Again, if it's related to the impacts of the program integrity rule, we don't have any estimates at this time.
Chicky, do you mind if I jump in here? It's Tasha.
No, I don't mind. Tasha from the Division of Financial Regulation might have a crystal ball, so please, Tasha, go ahead.
I don't really have a crystal ball, but hi everybody. I'll be presenting in a little bit on some information about rate review, but this is something that I am also involved in, and we did ask insurers about their DACA population as part of the rate as part of our rate review process this year. That information is publicly available, so you all can go spend your evenings doing that instead of Netflix if that's really what you would like to do. But generally, we heard from insurers. We don't have any like numbers. I don't have a number I can give you, but all of our insurers said that a very small impact. We don't have a lot of DACA enrollees, according to them, that would be impacted by this on the individual market. I do feel like this is going to be one of those things that we have to wait and see on, because we also don't know. There are some other provisions that Anthony talked about that could impact the pool and who is choosing to remain enrolled, not to mention the past due premium issue. So that is something that we are going to be monitoring. The division does put out quarterly enrollment reports. Not a crystal ball, but it will allow us to see if we are losing massive enrollment kind of throughout open enrollment and directly after, so that we can monitor it. But what we heard specifically on DACA from insurers, because we asked that question specifically, is that no insurer has a huge population of DACA enrollees in Oregon.
Thank you.
Thanks. Okay, so more to come on a lot of fronts here. We're gonna keep moving through the break. I understand that folks have been sitting or standing for a while, so please get up and do the things that you need to do. We just need to keep going because we're behind and there's topics we got to hit here. So apologies. Please do your thing. Let's move on to the network adequacy topic, which was a request in the prior meeting. Please take it away. I'm sorry we're running late, everyone.
All right, this is Jesse O'Brien. Can you hear me?
Yes.
Great. Great. So I am the policy manager with the Division of Financial Regulation at DCBS, and also a former member of HIMAC. So it's always nice to have the chance to chat with you all. When I was in a prior role, I was even the vice chair of the committee for a while. So good to be here with you all again. My part of the presentation is going to be talking about network adequacy, and then I'll be turning it over to colleagues to talk about the other requested elements to talk about. So this is just a quick overview of all the different parts of the presentation. I'll try to go through this fairly quickly, but there's a lot to talk about here. Hopefully it can be a conversation. Next slide, please. Okay, so network adequacy is probably folks are aware of this, but it's a term for the ability of a health plan's network to ensure that there are enough providers and the right mix of providers across the state and across different specialties and so forth, to make sure that everybody has reasonable and timely access to all covered services. The principle behind it is, of course, that you're not really offering an insurance benefit if people can't access the covered benefits. It at some point becomes an illusory benefit. The term network adequacy is maybe not the world's most inspiring way of talking about this. Like you in most areas want to aspire to something better than adequacy, but that is kind of the term that's used in this area. Next slide, please. Just quickly, I think this audience is likely aware of this already, but the network adequacy that we are talking about is the part that is subject to the jurisdiction of our department, which is specifically the fully insured commercial insurance marketplace. We're not talking about Medicaid or Medicare or other forms of coverage. We're really talking about the fully insured individual and group markets. And the individual market, of course, would include the individual market on the marketplace. But we are the entity that we at DFR, that is, are the entity that does network adequacy for those commercial plans, including the plans on the marketplace. Next slide, please. So our current, until the end of the most recent legislative session, our existing statute around network adequacy is cited here, ORS 743B 505, and that was the result of legislation a decade ago, 2015, that established Oregon's first specific law around network adequacy. And it has a few different components. It has a kind of basic requirement that networks be adequate to provide covered services without unreasonable delays. It gives us the ability to adopt rules related to this, and also requires an annual report from carriers about network access. However, it does not provide a very fine-grained level of detail around the rules for what constitutes an adequate network, which has been a subject of some concern over the intervening years, and we'll get into that in a bit here. Next slide, please. So in our experience trying to ensure that that networks are adequate, and in the kind of complaints and inquiries we get from consumers, and probably a number of you have heard about these issues as well in one way or another. Here are some of the issues we hear about. Many issues either directly or indirectly relate to the provider directories that insurance companies offer. That is, the list of all of the in-network providers, which also typically will list preferred providers or providers in tiers if the plan has a tiered structure. We hear anecdotally, and sometimes as a result of looking into complaints or investigating market issues, that provider directories are pretty often out of date or incomplete. So they will list providers who in fact have gone out of network, or have maybe stopped practicing altogether, or moved out of the state, or various other things. So there are issues with keeping them up to date and accurate. It's also difficult to provide and this is not entirely the fault necessarily of the carriers. I don't want to suggest that that's the case. I think that there's a bit of a two-way street here that makes it difficult. It's difficult for folks to verify which providers are truly in network and accepting new patients, and that's partly due to just the difficulty of ensuring that those conversations are ongoing between the carrier and the provider, given how many providers there are and how many things could be affecting that status. And then the other issue that we have seen in Oregon is a real lack of kind of specific quantifiable standards for network adequacy. So we will get complaints, or we will hear about situations where it's difficult for a specific consumer to find in-network coverage of a needed covered service, or where a large important provider is going out of network for an insurance company, and because we don't have a super clear standard established in our law for what the network has to look like to be compliant, we can't really. We're in a very difficult spot saying what is or isn't allowed. Whether, for example, if someone is told by their carrier that they have to travel what seems like an unreasonable distance to find to get an in-network service, when there's someone in their own community who could provide the service, there isn't kind of a clear benchmark for what is a reasonable distance or anything like that. And so that's something that comes up somewhat frequently. Next slide, please. And then, this kind of gets back to what I was just saying, but some of the key terms in the law are not clearly defined. Again, what is timely access is something that, is somewhat in the eye of the beholder, unless there is a clearly defined standard. And this creates ambiguity and confusion that ultimately we think has been problematic for all stakeholders involved, including the division in trying to ensure consistency and protect consumers, but also consumers themselves, of course, and ultimately the carriers as well, that they don't have clear guidance for what they need to be doing. And then also in the reports that we get, there's been a lot of variation in how those reports get submitted to us and how detailed they are and how well they address the kinds of questions that we would like to see answered. So that's another issue that we've seen over the years. Next slide, please. So, some background issues here that contribute to the problem include provider availability. As I think people are aware, there's a great amount of variation in the availability of providers in different parts of the state. There's decent access perhaps to a wide range of providers in the Portland metro area, Salem, Eugene, maybe a few other places. Even in those areas there can be issues, but there's a relatively robust community of providers of different types. But in the rural parts of the state, and especially the particularly sparsely populated frontier areas, there's a real scarcity of providers, and that's not anyone's fault necessarily. It's partly just the natural result of not having a large population in those areas. But it does create situations where people will sometimes have to travel very long distances to access needed care in those areas. And of course, we can't solve that problem simply by having a higher standard for insurance companies, because they can't create a network that's more robust than the number of providers that are actually there. There is a bit of a interplay between these factors, because perhaps in some instances providers would be more willing to set up shop in some of these communities if there were higher standards for network participation. But I don't think we could expect that the insurance industry could solve this problem entirely on its own. But it creates a problem not just as far as access for people in practice, but also in figuring out how best to apply network adequacy requirements in those areas, and what the standards should be, because you can't realistically impose the same kind of standard in a rural area. Lots of states and the federal government do have standards that reflect the differences between urban, suburban, rural areas, and different standards can be more or less granular depending on where you're looking. But in the especially the most sparsely populated frontier parts of Oregon, even the most generous standards are still pretty hard to meet, I would say. And then another issue that complicates network adequacy is telehealth, where especially since the pandemic, of course, there's been a big increase in the utilization of telehealth, and there's been some interest on the part of insurance companies to use telehealth more as a way of ensuring network access because, first of all, it can help fill those kinds of availability holes in underserved areas. Potentially, if people would have to travel a long distance, they could get services via telehealth. You can't get everything via telehealth, like surgery or whatnot, but a lot of important services can take place via telehealth. However, there was in 2021 a law passed regarding telehealth in Oregon that required that telehealth be covered and that it be reimbursed at parity with in-person services, but also prohibited the use of telehealth to meet network adequacy standards. That was an important consumer protection in making sure that telehealth was covered. But we thought it was a little went a little too far to say that telehealth couldn't even be considered as part of network adequacy, given how important it has become and how it really is a good option for a lot of consumers. Okay, next slide, please. Okay, so all of that is kind of background for a bill that DCBS put forward during the last legislative session, Senate Bill 822, which ultimately was successful, I'm happy to say. The bill passed toward the end of the legislative session, and it does a few different things to address the problems we've identified here. One that I didn't mention in the intro was that Oregon's prior network adequacy law actually only applied to individual and small group health plans. So that's the individual market, including all of the individual plans on the marketplace, but also plans available for small employers with 50 or fewer employees. The new law expands the standards to apply to large group plans, and that's only fully insured large group plans. Self-insured plans are exempt from state regulation under federal law, but this does expand the network adequacy law to include several 100,000 additional covered lives, so it's a pretty significant expansion. The reason for that is that we the original law, I think, was limited in scope in part because we felt that it was a baby step in the right direction, and also the biggest problems we were hearing about with network access were with individual and small group plans. But in the intervening years, we've seen that we do get complaints from people on large group plans, and we couldn't really think of a good reason not to extend those protections to people on those plans as well. And then another major thing that the law does is it gives DCBS the ability to impose quantitative, measurable metrics for network adequacy around time and distance and provider availability and wait times. That will address those issues. We will need to go through a rulemaking process, which is just starting up now to figure out the specifics of those rules. But the law does say that they need to be consistent with the requirements for QHPs under the current federal rules. The rules in place as of the beginning of 2025. It's very likely that the current federal administration will be changing those rules or possibly repealing them altogether, but we're not bound to what the federal government does there. We just need to remain consistent with what the prior rule was because we felt that it was a reasonable starting place. But we also do have the flexibility to impose state-specific requirements if there's a state-specific need to go into things differently than the federal standards. Next slide, please. Yeah, so I already covered some of this. The bill also allows the limited use of telemedicine to meet access standards, and that is also subject to our rulemaking. So one of the things we're going to be looking at in the rulemaking process is what level of telemedicine use would be allowed. Is there kind of a threshold for what we would allow to be used to meet the access standard, and would that be different for different types of services? Certainly there are certain services that you cannot really perform via telemedicine, but there are others where we already hear that as much as a third to a half of behavioral health visits currently are being done via telemedicine. So it seems like it would be reasonable to have a higher benchmark for those. Okay, next slide, please. So there's a few other things that the bill does. One is it explicitly adds to the list of services that we would look at in network adequacy, reproductive health and substance use disorder treatment. Also changes the phrase from mental health to behavioral health, just to keep it up to date with the latest terminology. These changes are really more about clarifying the intent of the law rather than the substance, because the network adequacy law applies to all covered services. But we thought it was important, especially to call out access to reproductive health services, given the level of public concern out there about ensuring that those services remain accessible. And then there's also a provision in the law that adds a requirement around enhancing culturally and linguistically appropriate care, that networks must be adequate to provide appropriate care to all enrollees, including those with unique access challenges, and explicitly calling out different cultural and ethnic groups, LGBTQ plus individuals, people with disabilities, et cetera. And the details of that will also need to be fleshed out via rulemaking, but we thought that was an important step in that direction. Next slide, please. Yeah, so that's the end of the slide deck on this, but this I feel like that only scratched the surface of the issue. So hopefully people will have some questions. Happy to discuss further.
Looking for hands here.
If not, people can certainly contact me via email. The email's on the slide here. Happy to chat about this further.
Okay, I don't see any hands. Thank you.
Thanks.
All right, moving over to filings, review, and updates. Please take it away. Thanks.
Is this me? Is this me?
I think it's you.
I think it's me. Hi, everybody. My name is Tasha Sizemore, and I am the Life and Health Product Regulation Manager. Today, I'm going to talk a little bit about the rate review process this year, what we have seen in rates, and then about some stuff that we are working on for rate review next year, and how this committee and people on this committee can participate. So the first thing I would like to say is that for many of the reasons Anthony discussed in his presentation, we had to change a little bit about our rate review process this year. Between the program integrity rule and just confusion and uncertainty in the market, we did take a step back and give ourselves a little bit of extra time to collect information from insurers on things like DACA and, as Anthony mentioned, gender affirming care coverage and the changes under the program integrity rule are things that we really wanted to collect more information on before we made a rate decision. So we're a little bit further out on our rate decisions than we usually are when I come and present at this meeting. So I'm just going to talk generally about what we saw in the rates. I'm not going to talk about where our decisions were. So in the individual market, we saw rate filing increase requests come in from an average of a low average of 3.9% in the individual market to a high average of 12.9%. In the small group market, the spread is a little bit larger. The low end of the average was 5.1%, and the high end was 21.5%. So there's some stuff going on in our market, and let's talk a little bit about that for a second. One of the biggest things that are impacting rates this year that we heard from insurers in their filings across the board for major medical, but I really need to stress this is not just major medical. We are also seeing this in the Medicare lines, and frankly, just anything that touches health insurance. We are seeing the cost of healthcare, the cost of utilizing healthcare to go up. So we heard from insurers that trend, which is comprised of the unit cost of obtaining care, so the cost of the surgery, plus the amount of utilization that occurs. That's what makes trend. We heard from insurers that trend has increased and saw that trend had increased pretty substantially, I think, from where we have seen it historically. The unit cost and some of the things that are causing the cost of care, maybe not necessarily the utilization to increase, but we are also seeing increases in utilization. But the unit cost is increasing because of medical inflation, provider contracting changes, and changes in the intensity of medical care. I haven't seen it so much discussed for the major medical market, but I do have to say that care modalities, even in my lifetime, have changed quite a bit. When I was a child, many of us were still relegated, I guess, to inpatient surgery centers. And if there was a surgery that had to happen, you could expect to stay in a facility for a couple of days. That has now changed. We're doing a lot more ambulatory care. Your hip replacement can be a very relatively quick procedure compared to what it was 25, 30 years ago. So for that reason, the costs of providing care and the costs of individual procedures and services are increasing. That being said, we did have some insurers in their rate filings report that certain service categories did see either increases or decreases in utilization. So that can be things like pharmacy, the prescription drugs or the number of prescription drugs can change, thereby changing the costs associated with pharmacy. Or just folks are engaging with particular types of care like mental health care or preventive services in a different way than they had previously. This varies a little bit based on insurers, based on the insurer. Some insurers reported higher utilization and lower costs, and other insurers, the script was flipped a little bit. So I just want to talk a little bit about what that looks like and the amount that it's increased for trend to demonstrate. So the average trend for medical in 2025 is 7.9% for individual, and for medical trend and 8.7% for prescription drug trend in 2025. The medical trend is projected to stay the same on average, but the prescription drug, the cost of prescription drugs and the utilization of prescription drugs is projected by insurers to increase. The trend on the small group market, I think for agents who are working with small groups, it is going to be quite a pinch this year because we are seeing trend just kind of across the board with small group insurers increase. So the average medical trend in the small group market in 2025 was 6.4%, and the projection for 2026 is taking that up to 7.8%. So basically 1.5%. Prescription drug trend for small group for 2025 is 7.6%, and it's expected in 2026 to be 8.1%. So like I said, we are seeing, depending on the carrier, either the cost of care by itself changing or kind of the utilization patterns of consumers really shifting over time. That being said, when we look at rates during the summer, we are looking at the rate filings and what will be sold to consumers for an effective date after January 1st, 2026. For small groups, we do allow quarterly rate filings and quarterly adjustments. So if that small group renews their contract in fourth quarter or something, there's a possibility for the insurer to make adjustments to the rates, and we may see that trend change in the quarterly rate filings. So this is, I guess, a plug that rate review in the group market, the small group market, doesn't stop here in a couple of weeks. That is something that we continue to engage with when we receive filings throughout the year. So that's what we're seeing in terms of rates. The final rates, Hunter is working on them. My project manager, he's working on getting that out, and insurers will have that hopefully by the end of today, and it will be posted on our website by the end of today. And the next public meeting where we're going to talk about our rate decisions and give time for insurers to either like to request additional consideration or accept the decision is scheduled for Monday. At this point, we don't think we're going to open up another public comment period for the second rate meeting. So if this is something that interests you, definitely engage, definitely join us for the meeting or watch the recording later. And if there are concerns, I would just, with the rate decisions that have been made, I would really encourage folks to use other portions of our process, including requests for reconsideration or the consumer advocacy unit to submit complaints so that we can continue to engage with this. Before I turn it over to Cassie, I'd like to just mention a couple of other things that are happening. And I didn't make the first part of this meeting, so this may have been something that was already discussed a little bit. There are two market changes that I'd like to talk to this group about. The first one is Pacific Source this year filed to move their plan designs on the individual market from a PPO type to an EPO type. The information about that decision is in their rate filing, but and we did receive one comment on it during the rate review process. But overall, it is a very well supported decision by Pacific Source, and it is something that we can expect consumers to react to, I guess, as they're making decisions about plan designs. The practical application of this is that Pacific Source's network, which has tended to be nationwide and allow members to more broadly used providers that maybe aren't quite as geographically close to them, that is not necessarily going to be allowed in the same way for 2026 and beyond. For Pacific Source, it is going to be a narrower network. Again, this information is in the filings, but it is a change. So if you are an agent or producer and have questions about this, please check out the filing information. I know even though she's not here today, Katie Button and I have been talking about this, and questions can go to either Katie or myself about this change as we are working on all of the notices that are going to go out to consumers and helping Pacific Source get all of that information out so it's timely. Things to get interesting on the call is that we heard from insurers during their public meetings, in the first public meeting and their rate filings, that that has had a biosimilar developed for it, and many insurers are moving to the biosimilar. I bring this up because this is usually, oh no, I'm breaking up a little bit.
We just lost kind of like the transition to this at a little bit of the beginning. So you're just freezing a little bit unless it's.
Oh, yeah. Okay, let me just, oh no. Oh no, did I lose internet?
No, you're still there. So you were, oh no.
Can you still hear me?
You were frozen for a while and now maybe you're back.
I'm going to turn off my video and see if similar for the treatment of certain autoimmune diseases has become available, a very popular. We heard from insurers that this is a change that either many of them are making for 2026 to the formulary or have already made this year. So I did want to highlight that for agents and producers. That is something that can tend to, oh no, did I lose you guys again?
It's just really in and out, unless it's just me. I don't think it's just me that know there's head shaking. Okay, it's just pretty in and out. You could either keep
put
going.
My last thing in.
Sounds good.
I'll over to Cassie. Yeah, no worries. Thank you guys.
All right. Good morning, everyone. My name is Cassie Susie, she, her. I am the insurance compliance manager for the Division of Financial Regulation. So my team oversees and investigates compliance issues for all insurance companies, health, life, disability, auto, home, you name it, we look into it. So I'll talk a little bit about provider contracting issues. We talk pretty often with companies about network adequacy. This gets into network adequacy issues where I think Jesse gave a really good overview of sort of how that potentially is changing with the new legislation as well as the reporting that we receive every year. My team is the team that reviews all those network adequacy reports and works with the insurer if we have questions after the fact, which will definitely help in that space. Another kind of portion of work, a body of work that our team does, working with another team that is taking on kind of pharmacy benefit manager complaints as well as provider complaints, is we do take in issues that providers bring up related to insurance companies and try to see if there is an issue with the company itself. I will note that our jurisdiction regarding kind of provider contracting issues is incredibly limited. So it really has to tie into our current authority with overseeing insurance companies. But we do take in those complaints time to time and look into them to see if we do have jurisdiction. Again, extremely limited, but is kind of a pathway that exists in terms of kind of how we oversee our insurance markets, as well as look to see if the contracting issue is something that is tied to a part of the insurance code that we could look into. In terms of kind of what we're seeing moving forward, I think there are quite a few issues around just contracting in general. Again, that's not something that we get particularly involved in related to the individual contracting and the negotiations that come up. Where our concerns lie really are around network adequacy, and that's really where our authority can come in around kind of provider issues, is if the insurer is or is not maintaining an adequate network of providers to for different care services, and looking into that further. So that's the information that I had on provider contracting. Again, my team really oversees all sorts of compliance issues with companies, and so happy to answer any questions that you might have around provider contracting, or get back to you with more information if you have anything specific. Yeah.
I'm looking to see if there are any hands. I'll just give it a little bit here. Let's give a chance. Okay. And then make sure, if you didn't see it, the biosimilar note in the chat. Okay, thanks very much to both of you. Amy, I think it's to you.
Yes, thank you, everyone. And I recognize that we're behind on time, so I'm going to try and move fairly quickly. But I'm excited to share with you an update on our SBM brand initiative. What I'm going to talk to you today is a little bit about a couple of different creative directions that we are considering and that we have presented to some consumer focus groups recently. So thank you, Dawn, for jumping into this first slide. So the first thing that I wanted to mention is that we decided to take two of our brand name concepts to the focus groups. And the two names that we decided to take forward based off of feedback was Explore Health and Chorus, which you might recall from the past, the April HIMAC meeting that we discussed. So our creative team over at Quinn Thomas took those two brand names and put together some creative concepts. So I have three different creative concepts that I'm going to show you here today, starting with Explore Health. Badge of Health is the title of this creative concept. This particular creative direction is really rooted in the vibrancy and vitality of Oregon's natural beauty. It really brings together the graphic elements of Oregon, really highlighting the lifestyle of Oregonians, featuring Oregon's, you'll notice that the badge, when we go to the next slide here, will feature Oregon's iconic peaks and Eastern Oregon's plains rocks. So these are the logo concepts that were put together. You'll notice that the colors are very vibrant, intentionally to grab attention. And we have a couple of different badge or logo options available. The lower option does include the subtext of Oregon's health insurance marketplace to further describe the brand. And if we go to the next slide here, it will further describe the badge and how it came to be. So you'll see that the badge includes 3 different mountain peaks. So we've got Mount Hood there, Three Sisters, and Mount McLaughlin. And then in the background, we have representing Eastern Oregon Plains. So we're trying to represent all of Oregon there. We will see that the color palette here is varied and bold, and that the text that we would use with this particular concept is pretty simple, but definitely to the point. You'll notice that the concept includes this line that would be woven throughout the imagery, bringing together the cohesiveness of the landscape and the thought of all of the togetherness that we're trying to bring together. And if you go to the next slide, Dawn, you'll see that the images that we would use with this concept are all in the lifestyle photography realm, really showing people in action in places that would look really natural to Oregon, and people obviously that would represent Oregon as well. So if you go to the next slide, you'll see some examples of what some advertisements or some use of this brand concept would look like. You'll see what social media might look like here on the left side. And then on the right, you'll see some example billboards or perhaps bus ads, if you will, and how that line drawn through the ad would actually draw the attention to from the text to the actual badge or the icon down there in the corner. So that's the first concept. And actually on the next screen, you'll see some example swag and what that might look like in the real world as well. And then on the next screen, you'll see the second concept, which is explore health as well, but it's live boldly. So this particular creative direction really celebrates that, you know, we have a wide range of lifestyles throughout Oregon. There's a wide variety of folks that live in Oregon, and there's a wide variety of landscapes in Oregon. And so this particular creative direction actually combines black and white photography with hand-drawn illustrations and bold colors. It's a really interesting combination, but yeah, let's go to the next slide. I'll just show you guys. So here's the logo concept here. So all text, you'll notice that the OR is called out in that blue-green color. And then similarly to the previous version of the logo, we do have the Oregon Health Insurance Marketplace is specifically listed there to explain what Explore Health is. And then on the next slide here, we'll see a little bit more details on the colors that would be used and the proposed fonts that would go along with this creative concept, as well as some examples of these hand-drawn graphics. Now you'll notice that these hand-drawn graphics would actually complement and be used as like overlays, for example, on the images. So if we go to the next slide, so you'll see some of the photography elements. Again, still in the lifestyle realm, there would be some more macro photography or like more detail photography woven in to this creative concept, but still showing Oregonians in real life, but focusing more, black and white photography brings more focus to emotion. So that's the purpose of this particular concept, is really focusing more on the emotion of the photography. And if you go to the next slide, we'll see some ad samples. You'll see how the graphics really play a role in really enhancing the photography and really painting a picture, telling a better story as well. You'll notice as well how the photography is really interacting with the graphic elements on the right side here, the billboard example, how it's overlaid with the boxes as an example. And then the kind of juxtaposition of the heavy text with the script font as well, which is nice. And then on the next slide, we'll see some example swag. I'm sorry, I'm moving quickly because I know we're short on time. And then the third and final concept here, which goes with the Chorus brand. So this one focuses on the concept of real life. And the creative concept here is really focused on 100% authentic snapshot style photography of real people in real life moments. So you'll notice when we move forward that the shots are not staged, they're not perfectly lit, they're not perfectly composed. They're going to feature people in real life moments, really the way that we would show friends and family our true selves. And this is really to build trust with our audience and make people feel seen and make people feel safe. And the concept also features logo Oregon prominently in the logo, and as well as framing all kinds of these human moments. So if we go to the next slide, you'll see what I mean. So this is the logo concept. You'll notice that definitely features Oregon prominently. And in the bottom concept here, we do include the Oregon Health Insurance Marketplace as well to make sure that we're tying that in and we know exactly what Chorus is standing for. Do want to mention that the nice little draw-in of having the R lead into the line of the outline of Oregon, which does kind of draw your attention into the OR a little bit more, and kind of calls out the us in Chorus a little bit as well. And then on the next slide here, you'll notice that this color palette is much more streamlined. So the thought process here is that we would really pick a color and we would own it. Similarly to how you would, when you think of some other brands, like for example, T-Mobile, you think of magenta, we would really pick a brand and we would own it and we would try and get that color to really, folks to assimilate that color with our brand. So that would be the thought process here. You'll also notice that, again, these photos are really intended to be snapshot style, real life, candid moments. And then we've got the outline of Oregon really serving as kind of a frame around the people in the pictures. And then on the next slide, we'll see some more examples of these real moment photography elements. Again, when we see pictures of newborns or moms holding newborns, oftentimes it's these beautiful pictures of, perfectly, moms with great makeup and perfect hair, but in reality, that's not how life is. So the photography here is really intended to, again, build trust and show people that we really do understand where people are coming from and that we want to meet people where they are. Next slide, please. So again, here's some examples of some advertisements and how this might show up in the real world. You'll notice that we do use really strong text and that these are very simplistic, kind of more basic ads because we really are focusing on the content and the real life nature of the imagery used. And then on the next slide, we'll see some swag examples. And then on the next slide here, we will have, we had hoped to have some time for some discussion. I know that we're really behind on time. So out of respect for your time, I don't think we will have time to discuss, but I would love your feedback on these concepts. We have not made a final decision by any means on the creative direction or the brand name. And so it is very important to us that we take feedback from all of our partners, which includes you all. So definitely would love to get your feedback on these different brand visuals and elements. And so if you would like to share that feedback with me by email, then that is definitely something I would love to hear, and we will definitely take it under advisement and consideration.
Amy, I was just going to ask, when do you need that feedback by email from folks?
I mean, maybe can we say the end of the month? Would that be good?
You can pick anything. We just need to know.
Okay, let's just say the end of the month. I think that's
Okay.
a good. Okay.
All right. Thank you.
Yeah.
And sorry
And I
for
just
the
have a
time compression. Go
You're
ahead.
totally fine. I'm good. I do have a couple more slides. I just want to make sure you all know kind of what direction we're going with the process here. So Dawn, if you don't mind going to the next slide. Just wanted to share with you all, as I mentioned earlier, we did hold some focus groups. These were actually held last week. So this is just a quick download and a quick snippet of some of the feedback that we got from our focus groups that we wanted to share with you. We did hear a lot that folks really liked seeing that Oregon Health Insurance Marketplace text along with the logo to really clarify what the brand's purpose is. So that's definitely was helpful. Folks really liked the idea of using real life photos and showing people in kind of the more real scenarios. So we really like that folks really like that authentic imagery. The bold colors were kind of divisive, but everyone agreed that it did grab attention. So that was really interesting to hear. And most people did really appreciate the Explore Health badge the most. That was the most popular design element. One thing we also heard that was something that we were very interested to hear from our focus groups. We did have we had 2 English focus groups, and one was for specifically rural participants, and one was for urban participants, and then we had 1 Spanish language focus group. And one thing that we wanted to learn from our Spanish focus group was should we translate the brand into Spanish so that we have essentially, for example, Explore Health and Explorar La Salud. Sorry, I'm testing my Spanish here. Or Chorus or Coro. And what we actually heard was that there were really no issues with just keeping it all in English. So I think that just reaffirmed for us that we don't necessarily need to transcreate the entire brand. We can just go ahead and use 1 English brand for all audiences, and that will just build a brand cohesiveness. So, but largely people did appreciate the Explore Health brand more than the Chorus brand. So that is something that we heard as well. And then I think I have just one more slide. Maybe I'm trying to remember. So this is just to kind of give you an overall picture of the process. And I know that we've talked a lot about kind of where we've been in the process and what we've done up until this point. So those are all the items that you see here listed in blue. We are currently in this stage where we are presenting to all of our sponsors and our team and leadership. And then the next steps will be making a final decision on the name and the creative direction. And then we will move to implementation, which is very exciting. And that will include really planning out our content strategy, what all do we need to create and develop, actually creating those deliverables, and then a brand launch, which we are planning to do in 3 phases. Initially, it will be internal for staff, both marketplace and OHA more broadly. And then we will move to partners, and then we will move to public. So intentionally, we are doing that in 3 phases so that we can make sure that our groups are very comfortable with the brand before we move on to a more wider audience. And I think that's all I have. So I appreciate you all listening to my very quick presentation.
Thanks, Amy. For folks not following the chat box, Amy's email is in there for feedback by the end of the month. Thank you. I think we're moving to public comment now, if I recall, possibly. There we go. Oh, I see that. Thanks, Chicky. Anyone here like to offer some public comment, or is anyone signed up for this session?
No one has signed up.
Thanks, Dawn. Not seeing any hands. Gonna give it a minute. Okay, I think we can move to wrap up. I want to thank everyone for their engagement and feedback today. I was just making some notes, number of follow-ups I heard coming out of some of the earlier presentations with requests for information back. Lots of questions about the final rule as well. So hoping to see more follow-up content on future agendas. You should have holds on your calendars, committee members, for October 16th, which is listed here. And then if you're looking ahead, I think also December 4th. So those are our upcoming sessions. Chicky, any other business matters that we should cover?
No, not for today, but please expect in October, we'll talk about, of course, open enrollment as per our usual. We'll also potentially talk about the baseline work plan for 2026, because, 2026 is not that far away.
Somehow, yeah.
So our usual stuff will be coming your way, as well as the other follow-up items that you all requested. So these types of information will come either through email or at the next couple of meetings.
Thanks very much, Chicky, and everyone, thanks for your time today. I hope you have a good rest of your summer, and I hope it's relatively smoke-free. Take care. Bye.